to get right into it, not wasting your time or the audience's, and ask you if you agree with many of the people who've been up on the stage today that we are both in a crisis situation in terms of healthcare, and that whatever the solutions we end up with may be, that there are solutions out there to fix the problem.
I agree with the entirety of the statement. First is that I wouldn't characterize it as a crisis in healthcare so much as I would characterize it as a crisis in how we pay for healthcare. The healthcare that we get in this country is terrific. We've got, when heads of state from all over the world come here for their healthcare, that tells you we should be doing something right. Are we doing something right in every place, every part of the country, and every part of the state? No, not yet, but we keep pushing.
So you think that the providers of care are doing a good job, the deliverers of care are doing a good job, but it's the funding mechanism or the payment system or the economics of it that are broken?
It's more the economics. I don't absolve the providers of health care any of the responsibility. At some point, they're following the payment mechanism, and
right.
At some point, you've got to incentivize the providers to have some responsibility. You maybe mitigate some of their risk on the low end, sharing some of the reward on the high, or not both. Don't completely make them absorb all the risk when things don't go right, but then take some of the reward when things do. So there's a mix in how we approach that economic funding mechanism.
Yeah. Well, you've seen this issue of economics from almost every possible side, as a practitioner, as a politician, and as an appointee leading a big policy effort. So I want to come back to that and ask you, draw on your expertise, but I want to first go to the statistics that we've heard quoted almost on every panel. 28.8% of the population without insurance, not counting the underinsured or the underserved, 6.2 million Texans. Is this the big problem everybody says?
It is a problem because we're a compassionate society. We're going to see to it that those folks get care in some fashion. That fashion is either going to be in the emergency room or more preventive care as folks start to get sick early, right, and that sort of thing. So right, it is a problem. I brand new to the job, sat at a Trib event with Ms. Ramshaw last year, and I said, but you got to look at who those folks are, whether they were uninsured for a week or 6 months or chronically uninsured. I think that matters when you're trying to figure out the delivery system.
The numbers don't tell the whole story.
That's right. I didn't want to be flippant and say, no, it's not 24% uninsured. It was more that I don't know, their individual circumstances matter in terms of how we create that safety net.
So not possible to regard the problem of the uninsured as monolithic. Within those Correct. Numbers may be different situations.
Correct.
Regardless of the circumstances of those individuals, do we have a moral obligation? You mentioned compassion. Do we have a moral obligation as a state to somehow provide those people with access to care? Or, as you said, do we already have a system in place? May not be efficient, may not be cheap, but we're already providing it.
When you say, do we have a moral obligation, you could be talking about the state, you could be talking about, my church or the Texas Trib. I mean, the question is, who's got that moral obligation? Fact of the matter is that I believe most Texans agree that they've got an obligation to look out for their fellow Texans. That's part of what helped create this state, was communities banding right. together, folks from distant places coming here and saying, this is the land of freedom, I'm going to help contribute. And so I think that I know the hospitals and the doctors and the physical therapists and many providers feel that moral obligation to do it. Question is, how far can they do that before their business model becomes unsustainable? So. Yeah. If the government is going to be the payer of last resort, as Medicaid is actually intended to be, right. then there's a place for that. There certainly is.
Yeah. You and yours, by which I mean the people around you at the commission, have been very careful to say Commissioner Janek does not take a position on the solution before us right now, the one that we're litigating, which is the expansion of Medicaid. Or as somebody said to me euphemistically, the leveraging of federal dollars. Let's not call it the expansion of Medicaid. Let's call it something a little bit more palatable. Is that correct, that you do not have and do not have not had and do not have a stated position on the question of whether we should do this?
If anybody spends any time looking at that subject, I think that you have to come up with some sort of a position. Do I as a person have a position? Do I as a physician have a position? But I've been entrusted with a job that gives me great authority to help implement this. And it would be a bit of a misapplication of that trust if I were to say, I think you should do this. And yeah. then a lawmaker sees that and they go, okay, well, it's not quite what he said. It sort of fits, but it doesn't. I want to stay away from saying, here's what I think should happen. The lawmakers have the vote of people behind them. I was appointed by the governor, but no citizen voted for me to have this job. And I take that very seriously.
Right.
I want to give them the information that they need. They'll direct me.
Well, let's understand then the org chart a little bit better, because I'm confused. Who do you work for? I understand I understand chain of command. I understand chain of command. You were appointed by the governor, and in the sense that you were appointed by the governor, you work for the governor. But the reality is you're paid by my tax dollars. You're paid by the tax dollars of the people here. Are you answerable to the governor? Are you answerable to the people of the state who pay your salary? Are you answerable in some way to the legislature? Help me understand, who do you work for?
My wife. I won't be flippant, but my wife's org chart may differ a little bit in what I'm about to tell you. I work for my wife, I work for my kids. Appointed by the governor. I appreciate the confidence and the trust that Governor Perry's placed in me.
Right.
If he ever said, Janek, you're doing a horrible job, I want you out, great.
He has the mechanism
He can
to do
that.
Yeah.
Absolutely, he can, and he should. If he's not in charge, then who? I can't go to 181 lawmakers and say, well, I've got this policy decision, let's call a quick meeting of the legislature and y'all tell me what to do. If you don't accept that, then who's left? Well, then me. I get to do what I want, unelected, top of a bureaucracy. I get to do what I want. That's the worst of all possible worlds.
Right.
So to answer your question as clearly as I can, I work for the governor, but I work in the constraints of the executive branch as placed on me by statute and by the budgetary considerations of the lawmakers.
Do you accept that in the course of you working out your own personal org chart that there are politics at play here? There are a lot of people who will say, quite matter-of-factly, that the reason that we have not advanced the ball on leveraging federal dollars is politics. That there are politics at the center of all this. I mean, I'm trying to understand how much of this is a disagreement about the best mechanism to insure more people in Texas, and how much of this is a more political argument about we don't want the federal government on our turf, even if there may be a good solution baked into that particular cake.
Because of the impact on the communities and on the people who need care and the people who provide care and so forth,
Right.
I would answer that it's politics, but it's based in policy. And I hope if anyone quotes me, they use the entirety of that.
Yeah.
But it's politics, but there are good, sound policy reasons for both sides making their argument.
Right.
It's not just to score cheap political points. These are big amounts of dollars and large policy decisions, and it is important for the policy makers to be grounded in whatever their political philosophy
But you understand that whatever the reality of it may be, the perception, which is often 9/10 of any conversation you're having, is that somehow politics are driving this conversation.
I won't dispute that some folks have that perception.
Right. So, okay. If you look at the economics of what has been offered by way of expansion, we're talking about an enormous amount of money that would be available to us for a finite period of time.
Sure.
Initially at 100%, and then it gradually goes down. Billy Hamilton, who was up on this stage earlier, the former revenue estimator, longtime employee of the Comptroller's office, in the report that he did for Texas Impact and for Methodist, if I'm reading the numbers correctly, in the 2014-2015 biennium, he says we're looking at freeing up, if we do some kind of embrace of the Affordable Care Act, $1.2 billion of the $3.4 billion of requested general revenue funds for various health-related programs across state government. So that's a lot of money, especially in a state that is historically austere. We don't bring a lot of money in the building, so we don't have a lot of money to spend. If suddenly $1.2 billion are available in the next biennium, freed up by the embrace of these federal dollars, that has the potential to make a difference elsewhere. Tell us why that's not necessarily the right thing to do.
I don't know whether it's the right thing to do. I can just show you those numbers, and I would say this. Billy Hamilton is a great guy, and I respect his work greatly.
Yeah.
I'm not qualified to go toe-to-toe with Billy Hamilton on the numbers. I would urge folks to look at this, though. It frees up some GR because there are some things that we currently do in the state that,
Right.
for example, covering prisoners, right? And there's no Medicaid match for that. It needs to be in that age population and so forth. We can do some things, and that would free up general revenue. However, it puts you on a trajectory so that later you're spending even more GR
Right.
to cover some of those things.
You're going to have to own those costs eventually.
You do. There's no doubt about it. Now, in another state, and there are some others, I've visited with my counterparts in other states who say, you got to understand, we don't really have a statewide safety net like Medicaid. That is our safety net, and so we depend on that, and yeah, we're going to jump in with Medicaid expansion. In Texas, we have something different. We've got this long tradition, I know you've heard me say this, and I'm sorry to be repetitive, but a long tradition of using the state-supported medical schools for anyone who wants to come and needs help. Commercial insurance, no insurance, whatever. And we've got this program through the counties that the legislature has made the counties essentially responsible for some of the indigent care. Some participate, some do not. And I think the first issue is that the right public policy? Are counties supposed to be in or not?
And do they even have the money to own that piece of business? I mean, the reality is, in a lot of ways, when we cut the state budget, we tend to let things roll downhill. And they're received by cities and counties who have to bear the cost that the state no longer wants to bear. So in some ways, aren't we just pushing the problem to somebody else rather than solving it?
And that may be the case if you're then saying, okay, so we're going to absolve you of some of that, so we'll do away with hospital districts and there won't be any more property taxes to do that. That's the quandary that the lawmakers find themselves in. If you accept new revenues through Medicaid expansion or something else, and it's covering existing population who's currently supposed to be taken care of through another taxing source, should that taxing source go away? In many ways, and I think we may have discussed this before at our previous Trib conversation, in many ways this starts to sound like school finance, except for it doesn't have the terms free and efficient in the Constitution regarding health care as it does in school funding. But
Is your perception that this issue of expanding Medicaid during this legislative session is dead? We had Chairman Zerwas and Chairman Coleman up here, and legislatively, with so little time left, this is such a hot potato. Even if the House passes it, we talked about the fact that the Senate may not. Even if the Senate were to pass it, the governor is not likely to sign it. Are we just fooling ourselves, wasting our time, thinking that the solution may somehow be legislative in this session?
There's some pretty smart people over there. I wouldn't put anything beyond their ability to get together. As you yourself pointed out, this is the session of cats and dogs lying together. We got doctors and nurses agreeing on scope of practice. We've got Republicans saying we've got to spend more money on mental health. I mean, it's a different time. You've got some very, very capable, very smart legislators over there who can do this.
But the fact is that the House just voted to instruct the budget conferees by a vote of 77 to 68, not even to really discuss in any way, serious way, the expansion of Medicaid as part of their budget conference. I mean, they pretty much telegraphed their hand on this, haven't they?
And the legislative session works its way, and if that ends up being what they do, which is do nothing, in other words, they do nothing and leave it, then there are plenty of people who would argue that we can still we at Health and Human Services, obviously in consultation with the governor and lawmakers, go and negotiate something else. We've got plenty of capacity in our existing ability statutorily to go negotiate something. And so I think, unless I'm reading it very, very wrongly, I think they need to decide over there, do they want to free me up? I'm already pretty free to do things. Or do they want to say, Janek, you don't go and talk about any of this stuff except within these parameters? I honestly thought that that's what Senator Williams' rider was doing, and to some extent what they were doing over in the House was to say, if you're going to talk about any of this, you don't bring back anything that anything you bring back must have LBB approval, and that means lawmakers, because lawmakers serve on LBB, and so they've not finished that conversation. They've got to sort those things out amongst themselves.
So you think the legislature is actually not tying its own hands, they're actually tying your hands, potentially?
The way I read Senator Williams' rider, it says, if you go talk about any of these things, you cannot implement it without LBB approval, and then they put a series of things in there that had to be taken into consideration by the commission. So there's a little bit of miscommunication amongst them as to what that rider means and what the will of the legislature is.
Do you want your hands untied? Do you want to be free to hop on a plane with Garnet Coleman or anybody else? Because it seems like the last time that you and Garnet planned a weekend together, that didn't go so well.
I'm always very careful. When I talk to lawmakers, I try to keep those conversations amongst us. They're free to say whatever, Janek said this or said that, that's fine, but I keep those things privileged. However, since he's chosen to spoke about it, speak about it.
Well, and Bob Garrett had the texts.
Bob Garrett had the text. Representative Chairman Coleman and I, he sent me a text message, and I assume everybody's seen it now, and it said, do you want to go to Washington, or can you check your schedule and let's go to Washington? Sure. No mention of what we're going to talk about.
Do you think you were going to a Nationals game? I mean, what? I mean, with respect, Commissioner, I expect you know what he meant, right?
Absolutely not, and let me explain why.
Yeah.
We've currently got the 1115 waiver with some major deadlines bearing down upon us. About the time all this thing started, we were facing some deadlines to get all of our plans out the door and to CMS for the 1115 waiver.
Yeah.
So we've got 20 regional healthcare partnerships around the state, depending on us to get everything to the feds. So the feds will look at it, CMS will look at it and send those back and say, this one looks kind of funny, you need a little more detail, or this one you're coloring outside the lines, you know, whatever it's got to be. And so they need to give us some direction, and then we can get it back to the federal government, cleaned up as they want to see it,
right.
And then they can approve the plans or not. That is one of the most urgent deadlines I have.
Right.
While I sit and wait for the legislature to decide if they want to tell me, do Medicaid expansion, don't do Medicaid expansion, or will remain silent, that's for them to decide. So I've got the 1115 waiver. I've got some other important information that we need to get from CMS regarding the Affordable Care Act and how we're supposed to implement certain things. We have weekly calls with CMS, State Operations Technical Assistance, SOTA calls. And in those, we get information, and they'll talk about where our plans are, or you know, how things are being implemented. And along the way, we say, by the way, we need some information on the Affordable Care Act and the MAGI eligibility determination, those sorts of things. So because that's the headline, it's easy for many people to assume that's what was on my mind. Truth is, I've got a lot of things going right now.
So you were not necessarily going to negotiate through some back door.
To negotiate what? And let me tell you, to negotiate what? If I were to go up and say, okay, what if we try this or try that, only to come back and find that very day the legislature had passed legislation saying you may not talk about that, it would be a waste of my time to start negotiating pieces when I'm not sure what the legislature is going to tell me.
To say nothing of the fact that the guy who appointed you probably wouldn't be too psyched to have you in there negotiating for something that he doesn't particularly want to see done.
I keep the governor's office apprised of what we're doing, what we're talking about, and that sort of thing.
So for the record, he did not scotch that trip. The governor's office did not, when they read Bob Garrett's column, say, you can't go.
Absolutely did not scotch that trip. Absolutely. There was no date set. There was no subject matter. It was a couple of texts. No personal phone calls exchanged to talk about it.
Right.
So.
And so if you said, I want to go, you think the governor's office would actually say grace over that?
The governor's office, I think, wants me here negotiating some of the stuff with the legislature on the current problems that we've got. Budget conferees have been set. We've got, you know, massive budgets to be considered. And I think my job is here for now. Let's see what the legislature decides to do on that subject and others.
Last question on this subject of negotiating. Wouldn't it behoove the state to have somebody in regular communication with Secretary Sebelius or her minions on this, so that in the event we're able to come to some kind of an accommodation, they know what we need, we know what they need, as opposed to nobody talking to one another and...
Short answer, yes. Would it be helpful to have somebody in direct discussions about just keeping the conversation open with CMS? And we've already got that. Between our managers of various programs calling their folks that they're responsive to at CMS, along with lawmakers, current lawmakers who have very good relationships with
Garnet,
the Obama,
for instance,
Representative Coleman, Senator Watson, Senator Van Depute. They have great relationships. I'm sure Senator Royce West does as well.
So the Democrats are being employed by the state to be the envoys to the Obama administration. I mean, nothing wrong with that, right? They probably have better relationship than the Republicans do.
Well, I can't say that, when you say they're being employed, I can't say that the administration has said, oh, Senator Watson, we want you to go, negotiate.
Unofficial. They're open. The lines of communication are open.
They're conduits because they have good relationships. But we think that the conversations can take place. once the legislature has given me some direction and the governor's able to look at what they want to do, if they come across with a piece of legislation on this or any other waiver, the governor will decide, is this good public policy? Will he sign it or not? And then we go from there.
Can I ask you about this question of tax credits? This has come up a couple times today. Becker reported on this in the Tribune a few weeks ago. This is the Families USA report that I think I'm referring to. That we have a health insurance exchange that gets created, say, by the federal government, because we've declined to create one here in the state. Is it not true that the tax credits available will help to insure a certain number of the people who are uninsured, provide access to care? That's something that will not be scotched, one imagines, by an act of the legislature or by the governor's office or by anybody else. That's going to happen.
That's correct.
Yeah.
Once the exchange is up and running,
right.
And just as a side note, one of the things about whether we would create our own exchange, there were a lot of things that the state had to follow the federal government on, a lot of things. And I've heard this from my counterparts around the country who
if we created an exchange.
If we created an exchange, it's
right.
basically we're creating it, but the federal government is telling us how to create it.
Right.
And that may be a semantical discussion, I don't know, but I think basically it was going to be a federal exchange one way or the other. Okay, so when they get their exchange created and Texans can go to that exchange and determine whether they're eligible for certain things,
right.
Then yes, it is true that some of that population between 100%, north of 100%, so 101% of federal poverty level up to 138% will actually be able to go into that exchange and get a federal subsidy, which will dramatically decrease the number of uninsured in the state.
I think it takes it down, the percentage down to 16% was the number that I saw. Is that right?
It can vary, but yes, I think 15%, maybe as low as 12, but
right.
but in that neighborhood.
So this is an immediate benefit. We become then immediate beneficiaries of this thing that we acknowledge we don't like, but nonetheless it's being forced upon us. The byproduct of which is going to be that a whole lot more people are going to have insurance than had it not existed.
It won't come without a price, and the reason is the feds are not only going to say we'll create the exchange, but they will determine what plans can be present in the exchange. And so that when you start talking about what an insurance plan has to cover, you're going to dramatically change the landscape. So if I were 24 years old, felt I was bulletproof, I don't care about picking my doctor, I don't care about which hospital you send me to, I just want to make sure that I get scooped up off the pavement and put back together, right? So I may get a lower level of service, but at a lower cost, and with no coexisting diseases, that may be fine for me. But if the federal government comes in and says, we're gonna mandate that you cover this and this and this and this, it's gonna raise the cost, and it will raise the cost for almost everyone.
Isn't it true that by allowing the feds to create the exchange, rather than our creating what you may well be correct in saying is an exchange that is a state exchange, but it's sort of at the federal government's pleasure, that we're ceding some regulatory oversight? If the state created an exchange, the insurance commissioner, whoever that was, would have a lead role in administering or regulating or overseeing. And in the absence of a state exchange, if we move to a federal exchange, that insurance commissioner is cut out of the process? I
think it's a matter of degree. Yeah. I think there was already so much we would have to do with a state-run exchange. The feds are going to say, as I mentioned, they're going to say, great, create your exchange, and by the way, here's how you're going to build it, here's how it's got to fit together. Right. So they're going to have tremendous amount of say. Utah had created its own exchange. It spent $500,000, a fair amount of money for a state with a population of Utah. They had created their own exchange, completely worthless. They had to shut it down because it will not meet the test, the standard. And they did this before. It won't meet the standards of what the federal government wants it to be. So ceding some control was only a matter of degree, and degree matters.
Okay. I want to ask you about costs. We had a conversation earlier today about cost containment from the perspective of different folks, hospital insurance providers, the state. People talk about how the percentage of the budget that is healthcare has risen so precipitously, that public education used to far and away be the largest percentage, I guess, of the unrestricted portion of the budget. Healthcare is rising to meet it and will race past it over the next couple of years. It's the thing that threatens to eat the entire budget. So I think we all agree we have a problem. We have to get those costs under control. We heard a number of people on the stage talk from their perspective about what they thought we needed to do to get costs under control. I want to ask you, you've been a doc, you've been in a legislature, you're now over this massive agency. Help us understand how we ought to think about cost containment, assuming, as I expect, you agree that that's got to be a priority.
It is a priority, and one of the ways to do it, and it's not just in Medicaid, but it's across the landscape of healthcare, is to empower those folks who make the decisions to have some responsibility for those decisions. I use this, I think I used this analogy before, but when suddenly I was the chief of staff and the director of anesthesia for a small brand new hospital and I was given a budget, I had the responsibility to look at whether I want the more expensive anesthesia machines, which would free up less money for certain other things. That is a far different mentality than if I'd been told, here's the cheap anesthesia machine, this is what you're going to use. By virtue of the fact that the providers and patients, and I think the patients are an enormously important part of this, put them in charge and say, here's the money you're going to get. How you spend that is going to be up to you. Yeah. Now that gets kind of weird until you start to look at the landscape, the current existing landscape of healthcare and how it's changing. We see doctors forming larger groups. We see a shift that's been in place for some decades, but a changing demographic and a changing attitude amongst tomorrow's doctors in terms of what they expect out of their professional practice and so forth. And so we see larger groups. We see consolidation of some of these groups. Eventually you get what we once called an integrated practice association, an IPA, or we create an ACO. They all mean kind of the same thing, which is you bring one model together with the docs and the nurses and the speech therapists and the physical therapists and the hospitals all coming together with some important input from experts in insurance, accepting risk, which is what insurance is about. They come together and say, we're both the providers and the plans. And so now pay us on a per member per month basis, and we will make decisions, we will give good care, and then you follow us for outcomes. Right now, and this is an important piece, right now we create this regulatory structure and we say, okay, doc, we're going to pay you to do this. Oh, and by the way, we're going to watch to make sure you don't do too much of that. And so we're going to put some constraints, and before you know it, before you can do that, you got to call and get permission from somebody you don't met, and your office is on hold for an hour and all that sort of thing. Yeah. So we try to strangle good practitioners with this regulatory contraption instead of saying, hey, doc, you make the good decisions, we're going to pay you to take care of that person. You make good decisions. If you can cut costs and deliver the quality care, go do it. Right. If you can't, you still got to deliver the quality care. Accept some of that risk and enjoy some of the reward.
With the costs capped here, regardless of how you spend the money below that cap, that's the limit. I mean, I understand that removing the directives or the mandates on many of these providers is what they want. But of course, the other thing that motivates many of these folks, because why wouldn't it, is they want to make money.
Sure.
And so isn't the desire to make an adequate or a better than adequate profit the real push against cost containment, or a push against cost containment, no matter where you're looking in the industry? Isn't that going to always be a motivating factor?
It is, but it's compounded by the fact that we pay poorly. Oh, and by the way, we make it really difficult for you to begin with. And so it's got to be one or the other.
At least we're going to remove the things that make it difficult for you.
Decisions on cost containment have to be made. I think we would all agree we're not going to expend the entire gross state product on health care. I think it's fairly simple.
We prefer not to do that.
We'd rather not, because there's some other things we think we need to do.
Right.
And so if cost decisions have to be made, the question to be asked is who gets to make them? Bureaucracy, private corporations, patients and doctors, a mix of all the above. It's got to be some mix of all the above, in my opinion. And so, yes, we're a big player, and everybody says as Medicaid goes, then the plans sort of follow them, and it becomes, that's not necessarily so. We learn a lot from Blue Cross and Blue Shield, United, Superior, all the other partners in Medicaid. We learn a lot from them, sometimes just through contract negotiations. But we learn a lot from them, following their lead on certain things, and the plans are constantly pushing us to get better at our game. They're now, we've got this dust up about the formulary, and the state holds the state formulary, the compendium of drugs that we'll pay for with no strings attached or no questions asked, and then if you want something that's not a preferred drug, you got to get permission ahead of time. We learn from the health plans on how to manage some of those things, and we get better at our fee-for-service game because of what we learned from the plans.
On this cost question, let me ask you about a request that the Commission recently made to increase Medicaid premium rates for managed care companies.
Yes.
That just happened. Yeah. Can you explain why you're doing this? I mean, there may be a good basis from the perspective of the managed care organizations, but the out-year projection on the budget is that this somehow balloons the state's expense.
Yeah. We are mandated by federal law to pay actuarially sound rates to the managed care organizations. Mm-hmm. We have to do that.
Right.
We were going into a new market with some of our partners in the managed care field and saying, okay, this is a new market, we're going to open it up. It's not Houston, it's not Dallas, it's the rural service areas and some other more populated than rural, but some new areas. And every time you ask somebody to go into a new area and accept some of that risk, everybody's balancing a little bit. The truth is that after we've looked at what the experience was from the health insurance plans, and we get access to a lot of their data, a lot. When we looked at what their experience was, then we looked and said, you know what, we cut a really good deal, but we cut such a good deal, we're at risk of getting some of our partners to say, you know what, thank you very much, but my bosses, my shareholders, whoever won't let us participate in that realm. We want out, in which case we're not going to be able to benefit from some of what managed care has to offer, especially in the rural service areas. Again, a new market. We weren't used to doing it. They weren't used to doing it in this market in Texas necessarily with this population. And they're a different population. And so I think when you look back and say, did they have all the information they need? We hope they did, but it probably wasn't. In hindsight, those rates were not very sound, and go take it to the lawmakers. So it wasn't my decision to increase those rates.
It'll be up to them to go up or down, but you made a request.
But
the upshot, Commissioner, as I understand it, is it's going to be a couple $100 million just in the last few months of 2013, that the expected costs to the state budget as a result of this request, should it go through, in the 2014-2015 biennium will be significant.
I think it's going to be far less than that, but we'll see what the appropriators, where they eventually
Do you have any
end
idea
up.
where they're going to get the money from?
It's not going to be a couple $100 million. It may be getting close to that in terms of all funds, but no, in terms of general revenue, that last piece for the end of this biennium was probably on the order of $40 million, and I may need to reserve the right to dial back on that. But for the end of the current biennium, and then going into the next one,
you think it's actually less of an expense?
I think it's less. Yeah.
If the managed care organizations deserve a bump up because they got a raw deal, that's my paraphrase, then why have the reimbursement rates for docs also not worthy of a bump up? I mean, we've heard a couple times on this stage people say that one of the big problems right now is that reimbursement rates are not where they need to be. You got a lot of docs who are opting out of taking on this responsibility. If the MCOs deserve an increase, why don't the docs deserve an increase?
Part of it is, again, when you go back and look at what the actuaries tell you was a sound rate for that particular population. And so you're covering more people. Each person is taking maybe a larger percentage of medication. Each person utilizing a larger percentage of services that they need. And so you're spreading more of that cost amongst more things and not necessarily that doc getting a larger reimbursement. Again, it goes back to what I said earlier. If we can form those important relationships, I say we, it's not up to the Health and Human Services Commission to form ACOs, but as the market trends in that direction, when a big one pops up, Scott and White is a good example. We don't negotiate with other plans necessarily with Scott and White. You negotiate with Scott and White as a plan, and so they're both the provider and the plan. They come. Children's hospitals are another very good example of that. They're both the provider and the plan, so you negotiate that per member per month with them directly.
Whose decision is it to raise the reimbursement rates for docs?
It is up to, on the fee-for-service side, it is ours. And in the managed care side, it's up to those individual managed care organizations as to how they're going to reimburse the
You're
docs.
aware of no such plan on either side of the line to jack up reimbursement rates at this moment? Any plans for this to happen, for this issue to be addressed with?
On the fee-for-service side, we're constantly adjusting rates, sometimes more, sometimes less, based on what Medicare pays and so forth. And so on the fee-for-service side, we're increasing some rates, decreasing some others. On the managed care organization side, it depends on each of the multiple partners that we have in this dance.
We're going to have a panel in a couple hours on the state of women's health in Texas. We have now 4 months or so under our belt the conversion of the federal women's health program to the state women's health program. It was a little rocky at the beginning there, but now things are quiet. I don't know if quiet means that things are fine, or if quiet means that other attentions have have kind of overwhelmed those. Update us on where we are. Tell us what we should know about the status of that conversion.
Sure. TWHP started on January 1, and with a new program and at least a new spectrum of providers, some of the old providers not participating, some new providers coming in that weren't in the Medicaid Women's Health Program. You wait and see there, because there's a lag time between when the services were provided, when the bill gets to us, when the bill gets paid. So here's what we look at. Even though it's now late April, we look at the bills that came in for the care that was delivered in, let's say, January, February, and knowing that they've got up to 6 months to get those bills in. You get most of the bills in within that first month following the service delivery, but then they continue to trickle in after that. And so, judging on the claims that we had in January of 2012, we were getting pretty close, and I'm sorry, I'm blanking on the numbers. We were getting pretty close to the performance that we had for January of 2012. So 13 wasn't too far off, but it was less. Yeah. There were fewer visits, fewer claims made in January of 2013 than in 2012. Will the projection eventually get us where at parity where we were under Medicaid's Women's Health? I can't say. That's up to the patients and the providers, and it's also up to how good a job that we do.
Bottom line, though, is you believe that the services necessary are available within the state program to replace what was lost at the end of the federal program.
I do, and there's a couple of caveats to that. Number one, time was going to tell us whether our geography is right. You know, you may have plenty of patients in one area getting good service, but we need to make sure that the geography covers the entire state. So if you've got an area that's still lagging, we've got to bump up the efforts to make sure we have providers in there. A lot of the dust up when this first started was we had crummy lists.
Provider list
had anesthesiologists.
Had holes in it and people who couldn't provide the services and all that.
You had women going to say, well, that's really nice that, you know, Dr. Kyle Janek, I'm not practicing, but Dr. Kyle Janek's a provider. I don't need an anesthesiologist, thank you. I need a primary care doctor. And so that's the list that we had maintained in terms of who is allowed to be a Medicare billing entity. And when we were first asked for the list, that's what we did. And you know what it turns out? Our Medicaid list was sort of the same way, but it wasn't a political issue, and so nobody called and said, hey, I want to see all the providers in the Medicaid Women's Health Program. Had they done that, they would have gotten the same sort of disjointed
So you
list.
put the list up, and then you had to pull the list down to clean it up. List is back up, and you believe now that the list is where it needs to be.
I believe the list is far better than it was, and yes, I believe it where it needs to be. One more thing on this, because it's important. Part of the discussion that I've had with lawmakers in committee was, okay, so over here you've got Texas Women's Health program, you've got some primary care over here for women that will include planned birth control and that sort of thing. How is somebody to know? Our goal here, and I don't have a time frame, but our goal is to make that access, that portal, easy. Now, right now, a woman could call 211. A woman could go to various websites, but I want to blend these things together so that a woman who's not supposed to read the newspaper every day and find out what the latest is on this program or that program can get in and find the services that she needs. We've got women who are trying to be responsible. They're trying to look out for their health and not bring children in the world they'd have to either give up for adoption or have an abortion. They're trying to be responsible. And that is even beyond the trying to be responsible and getting screening for cervical cancer and getting screened for diabetes and getting screened for breast cancer. So we got to get better. I can't stop and say it's good enough like it is. We got to keep getting better.
Okay. A couple quick additional questions before we open it up to the audience. Demographics in the state, which you alluded to, changing dramatically. We'll soon be a Hispanic majority. Population is growing quickly. The composition is changing. And the locus of the population growth is particularly interesting because where the population is growing the fastest and changing the most are in places where we as a state have historically invested less.
Yes.
So what do you, from the perspective of the Health and Human Services Commission, do to meet that population change head on, not reactively, but proactively? Because clearly the state in 2040 is going to be a different state than the state is today.
Certainly. One thing is to make sure that infrastructure is in place, the manpower, person power, if I need to be a little more correct, but that individual infrastructure is in place so that we've got providers out there. TMA and the nurses are doing a great thing by coming to some agreement to make this not a political hot potato. But they've come to some agreement about what advanced nurse practitioners can do under the guidance of a physician and pushing some of those services out into areas that are currently underserved. So job one is to make sure the infrastructure is there. We need more doctors. Heaven knows we need more nurses. And we need them willing to go and stay in parts of Texas perhaps where they grew up. I think we're going to get a great deal of help from new proposals or proposals for new medical schools in the Valley and also here in Austin. They're a jewel, and we need to utilize those as much as we can. Real quick, we've got a shortage of psychiatrists. We can't get psychiatrists to go work at Rusk State Hospital. We can't get pediatric child psychiatrists to work in certain areas. They're usually out in remote areas, and it's not a sustainable practice by itself. And so that infrastructure of knowledge is critical to meeting the demands of this growing population. And that's even, never mind the changing demographics. Yeah. I'm no big fan of affirmative action as a means to the end, just in and of itself, I should say. But I do think about when people go to a doctor, what do they look for? And this is changing, and I'll see some nods through the audience, I'm pretty sure. My mom, bless her heart, my mom's bedridden, she lets me speak for her now. She said, I would never go to a woman doctor. That just doesn't seem right. I hear the groans. That's a generational thing. And what we see now is women want to go to women doctors, right? And sometimes it doesn't matter. If you got a cardiology problem, you don't really care. Somebody quick, make this chest pain go away. So we need that face of medicine to grow with the population, and frequently that means the demographics of the face of medicine as well.
We'll let the audience in here in a second, but I got to ask about mental health. You made a point about Republicans finding money for mental health. Garnet Coleman was here earlier praising the legislature for finding funding for mental health. This is all maybe in light of, or maybe not in light of, the national conversation we're having about mental health after some of these horrible tragedies that have happened related to gun violence. What is it? I mean, why did we finally come to some understanding on this issue after so many years of fighting about this, where there was a sense that the legislature was actually not doing anything adequate on this subject?
I think it focused the legislature's mind away from this is not something abstract. It is not in the abstract, someone's got some minor mental issues. This is the serious nature of what some of these folks are capable of and what they will do. So you have to look at the system of mental health delivery. How did some of these folks, maybe where they were identified early on, but they fell through the cracks, nobody acted upon it. And that's a much bigger issue. It gets literally into constitutional issues about what do you do if you've got somebody who is mentally ill, and yet the Supreme Court has said you can't do anything about it. You can't do anything unless they're a risk, danger to themselves or to others. So it just opens some eyes that this is not necessarily about the weaponry used, but it's more about the affliction that people have that causes them to commit some of these things. I'm not going to opine on the nature of good and evil, but I do know that many of the folks who commit some of these crimes have serious mental illness, and this legislature is focused on it. I saw Chairman Coleman early on when much discussion was being had on more dollars for mental health, and I looked at him and said, things seem to be moving in that direction. He just grinned. He said, I'm staying out of the way. It's all going fine.
And so is the hope now that those dollars will provide more adequate facilities for people to be dealt with? Because in a lot of the counties, as you know, the county jails have become the psych wards by default.
Yeah. Some of it's the facilities. Some of it is Dr. David Lakey, our terrific commissioner of Department of State Health Services, has pointed out. We're sort of operating on, facility-wise, we're operating under an old model. Mental hospitals were once the place for you to go and spend the rest of your days because we didn't have good drugs, we didn't have good treatments, and that's where you went. And so we put them in areas that were rural and idyllic, and they wanted the jobs and all that sort of thing. And so part of it's about the facilities. Our facilities for the state mental hospitals run at about 90 to 94% capacity. When they get to 95% capacity, it's becoming a real problem. And so part of it is, do we need more beds, and where are those beds located? Yep. It doesn't mean we have to build new facilities, by the way, because frequently DSHS can contract out for that care to the community, to the hospitals and doctors currently serving in a particular community. They can contract out those beds. So we don't have to do more of the old model, just update, just more of it. We need to sort of update our thinking about mental health.
Good. All right. Excellent, Commissioner. Thank you for your perspectives on these issues. Let's take questions. We have about 15 minutes, and we're happy to have you put your hand up and jump right in here. Hands. Ma'am, over there. Yes.
Hi, Commissioner Janek. First, I want to give kudos to your staff. Stephanie Muth, Kim Bazan, Liz Garbett have been wonderful partners for those that advocate to help families that are eligible for CHIP and Medicaid get through that system. And they have been meeting with us on a regular basis to educate us on how ACA is going to be implemented in our state. How are we going to help folks through? Where do they apply? My question to you, when I hear you talk about why Texas didn't choose to create our own marketplace, and I hear you say that it'd really be a federal system, one of my concerns is, especially if we don't create a Texas solution to cover those families that would be eligible for a Medicaid expansion, those of us working with folks are going to have to think through, okay, where do you kind of fit? Well, your kids are eligible for Medicaid or CHIP, and so you really should go through the Your Texas Benefits door, but you might be eligible for a subsidy. Well, now we'll take you through the marketplace, and oh yeah, your information is supposed to go back and forth, but we know it all hasn't been built, and so I'm really afraid.
And your assumption is that if the state built an exchange, it would be more streamlined.
Could it all go into one system, and you would process it all, and we would minimize these folks falling through the cracks?
Is that not an argument for the state to create something that's...
It makes sense on the face, but I can tell you this, that folks will be able to go to that federally run exchange. That's how it's designed and should be implemented. They can go to that exchange and find out whatever they're eligible for in terms of health insurance. Now the question becomes, can we interface that exchange if someone is looking for something else? And if they're saying, I've got insurance, even though I'm Medicaid eligible, I may have insurance. My kids are Medicaid eligible. I have insurance. They're covered. But now we're looking for, food supplements or TANF or something else. And so we want that exchange to be fluid. And sometimes, not always, sometimes it's our fault, or it may be our fault if it's not, but it will certainly be many times when it's the federal responsibility as well. A quick example. TANF, temporary assistance for needy families, does not always mesh entirely, and I think Commissioner Muth would back me up on this, does not mesh entirely with the Supplemental Nutrition Assistance Plan, SNAP, food stamps. And so it needs to be fluid, and one of the things that I want to do, we've had some discord with just a few lawmakers who hear that we're closing an office in their county. You're closing a state office for eligibility in my county. You're walking away from my county. To their credit, and all these lawmakers, we've spoken with them and said, no, we're not. We're closing the office because rather than people have to leave work during state hours to go to the state building and stand in the line at the state building to talk to the state employee, can we do a better job of pushing eligibility determination, not the final enrollment? That's the responsibility of a state employee. Again, feds make us do that. You have to have a state employee make the ultimate determination. And so, but let folks get out there in the community where they're already going. They're already going to go to the United Way or to a local church or to the food pantry. And so there's a way to get those services out to them without making them exist in the confines of our office hours and the like. We're going to constantly work to make these services available to whoever is legally entitled to them. And if we're not doing a good job, Stephanie Muth will make sure I know we're not doing a good job, and I'll give her the resources to do it.
Questions?
Thanks for the compliment on the staff, by the way. It's unbelievably how blessed I am with the number of people over there who know this job. I joked last time, it's not much different now. We split the work up evenly. It's all 50-50. They do the work, I give the speeches. They're unbelievably talented people over there who keep this machine humming.
Speeches are easier than work. Questions for the commissioner?
and Dunkelberg must have left. I tried to
I know, yeah. We timed it.
I tried to get her car towed just
Ann
to make
left
sure.
about 15 questions.
Tell her I miss her. Got to be something.
Anything else for Commissioner Janek? Ma'am in the back, right there.
So there's talk about maybe having a Medicaid block grant rather than maybe the expansion. Is that a possibility, or is that just a wishful
Well,
thinking?
you all would like the big cartoon bag of money with the dollar sign on it to fall from the sky, wouldn't you?
It's not a bad thought, and here's why: is it lets us have some of that authority to not worry about. Well, we've got to ask permission to do that, and that may take a few months. And the system gets pretty disjointed in small ways, little tiny things. But that tiny thing is the difference between success or failure for that patient or that clinic practice. And I could go on for a long period of time talking about the number of times we'd like to do that. If we want to change rates, if we want to increase rates, we've got to go back to the feds and say, may I? Are we allowed to change rates? We want to decrease rates, up, down, whatever, we've got to go ask for permission. And so, can we design a system? Could we design a system with a block grant? Remember, the states did this back in the mid-90s with welfare reform. Federal government, Congress, President Clinton signed it and said, we're going to let the states have much more latitude. We'll do much more of a block grant fashion. They give us the money. We make it fit for the folks who need those services. Is it a possibility? Everything's a possibility. All politics is about possibilities. I don't think it's terribly likely, but we should ask. And barring that, we should say, okay, short of a block grant, can we do this? How about this? We're constantly asking.
The problem, Commissioner, though, is intractable. We know it's intractable because it was a problem that extends before the Perry administration into George Bush's time, and before George Bush's time into Ann Richards. We have had a problem with a high percentage of uninsured for a very long time. If the problem could be solved easily by a block grant, why haven't we solved it? What confidence should we have, based on how intractable this problem has been over time, that you all, by which I don't mean you personally, can solve this problem if we simply gave you the money to solve it?
Well, primarily because it allows us the flexibility to use, and I know that word gets overused, but it allows us the flexibility to use the resources that we have, rather than here's how the program works, and now you have to ask for permission to do anything.
Tell me one thing that you would do, freed of government regulation, that if you had the money available to you. Tell me one thing that you either know works or that you believe would work, that if freed from those strings, you would want to see implemented.
Okay. In the current existence, if we were to contract with a dental practice, for example, and say that dental practice, we want to pay you X amount, never mind the dental managed care organization, we want to pay you X amount to provide dental care for people who sign up for Medicaid dental benefits, okay? So we'd like to pay you X amount. You know what? If you can prove something else that makes your contract that much better, or that you can then use to reach out to people, then great. In any other business, a practitioner who would say, great, I'm in business with you, and oh, by the way, I got transportation covered. I'm going to send my vans out. I'm going to send our transportation modes out to folks. If they want a dental appointment, we'll get them a dental appointment, and they get to come to us. It's illegal. It's illegal in Medicaid. That is called an illegal inducement. Can you imagine that? If they give a value-added service to a patient to say, come in, we want you to be part of this, it's an illegal inducement. Right now, we've got dental practitioners who are so worried about that sort of thing that they say, I can send these vans out for other patients, but if I go to a health fair and advertise that I send vans out, whether it's for a Medicaid patient or not, it's an illegal inducement. There's your one thing. I got more, but
well, okay, so
you only asked for one.
The point here is innovation is stymied and entrepreneurial
Stifled.
sensibilities are constrained by these rules.
Absolutely.
We got time for another question or two. Gaylord, this will be a good one. Watch out.
I'm sure.
Yeah.
Dr. Janek, thank you for coming today, but thank you for being our commissioner. You and I have known each other a long time, and you're doing a great job, and glad you'd be willing to do it. And this is kind of a follow-up. You have indicated there's lots of communication maybe between you, maybe members of the legislature, and either HHS or CMS about what might be acceptable given the Zerwas bill, a Texas solution, and obviously even when it came to the instructed limitation, that Representative Creighton put on the appropriations. The fact is, he went on to say, we think there needs to be specific legislation, not some rider in appropriation bill. There needs to be a policy set by legislation. Are you receiving, or Dr. Zerwas, the legislative leadership, receiving anything back from HHS or CMS about what they might accept? I know Arkansas hadn't heard about their health insurance premium approach, but are we getting any feedback that hopefully he could include in a bill that might move?
As I explained in the appropriations process, we're not asking those specific questions right now because I don't have the direction of the legislature. And I know Representative Chairman Turner said, you know, there's no plan. Even Arkansas has a plan. Truth is, it would be a waste of time to go and say, what if we do this? Give me the list, the checkoff list that CMS would accept, and I'll run that back to the legislature and do that. We do have conversations with them all the time. My 2 conversations with Cindy Mann, the Director of Medicaid Services, has revolved around, number one, was an introductory meeting. I went up to visit with her in late October, I think, of last year. And then later we had a phone call wherein we talked about TWHP, the Women's Health Program, and how we were going to implement some certain provisions there. But nothing direct from me to Ms. Mann about, how about if we try this and that? There's no conversation because we don't know what to converse with them about until the legislature finishes its job.
You see, it's a chicken egg question.
It is.
What does the legislature go to do without an idea of what might work? And that's why
The legislature is free, as they've done many times in the past, and say, go negotiate a waiver on this specific topic. That's not new. They've done it before, and they can send us direction. They did it in Senate Bill 10 a couple sessions back, and so they can do that, and it's.
But
I
it's
can't
but again, it's specific. It's got to be a specific. So the likelihood that the legislature is going to say, Commissioner Janek, go up to Washington and whiteboard with HHS and come back when you got something to talk to us about, that's not likely to happen.
Or they could say, go up and talk about anything you want, or they could say, don't go up there and talk about it. It makes more sense to me as an unelected official to wait for the legislature to finish its work for this session and say, go do this or that. I mean, there's always going to be another session of the legislature, but it really is problematic to start getting into some of this while the legislature's in session. It leads to poor communications with the lawmakers. We don't want that. We don't need that. They're in charge of drafting the laws. We'll ride this out and see where they send me.
All right. Well, we're at 1:30. We're going to let Commissioner Janek go back down the street. We appreciate enormously his time here. Let's give him a hand.
Thank you.